We went to Ruleville, Mississippi, Richmond, Virginia, and Los Angeles, California to learn more about the decisions that patients and caregivers who are living with cancer and other chronic diseases make during their long illness journeys. We wanted to understand what shared decision-making means to these individuals and their communities, what barriers exist to good communication and trust with healthcare providers, and what obstacles stand between patients and access to the remarkable advances being made today in cancer treatment and care. These are some of the people we met on our journey. You would think I would know by all this, how many things that we've done to go off mute before I start. So thank you. That was a wonderful panel, and the panel really set up some of the things that we're going to talk about in this presentation. And also thank you so much to Dr. Robert Gwen, who is one of our partners in this project, and who really dug into, as Ashley said, the idea that the future is here, but it's not equitably distributed. And so we're going to look at some of the, look at what we've learned as we've gone through three communities in person, which was a great, really a great privilege at the, right after the pandemic, to be able to meet people, not just where they were on screen, but actually where they were physically. And we went to three very, very different places. So Chris Wilson and I are going to talk about our project, Shared Decision Making, our NPAF's project, Shared Decision Making at critical points in a long illness journey. As I mentioned before, we are very grateful to the Danaher Foundation, who funded this project and made and gave us the opportunity to really look at, as we've said as a theme, both what choices, how people make decisions, the choices they have, and also the choices that they make, and how we can facilitate making those choices in a way that really maximizes people's access to the care they need, they deserve, and that they want. And you'll see that's one of the other themes throughout this is the care that people want and the decisions that they want to make. So we've talked about choice a lot throughout this. So today we want to thank the Danaher Foundation for funding this work. We want to thank our partners for their remarkable co-creation of the workshop. As I mentioned in my introduction, everything we do, we co-create. It's one of our fundamental principles and values. And this was, of course, no exception. And there were tremendous, it was a tremendous collaborative project. We want to report on the year that the work that we've done this year to date. As I said, we have a few more things to do, discuss what we learned, and then discuss what we're going to do to advance shared decision-making and patient-centered care with a health equity focus. So just to give a little grounding in this, the project goals and objectives were to learn more about the decisions that people with serious and chronic disease face, learn more about patients and how patients and their healthcare teams make shared decisions, learn more about the systemic barriers that prevent patients from gaining access to optimal treatment and care. And through Dr. Nguyen's presentation, through the panel, we've talked about some of these systemic barriers. And I was, when Tamron Collins talked about her patient, the barrier was time. The barrier was the time left in the remaining time in his life. The barrier wasn't financial, but the barrier was travel and travel time. So often we reduce things and assume that there's one cost, there's one barrier, but there are always multiple barriers. And I think that was a really very strong, a very important reminder of that, that there are multiple factors in that choice. We want to develop, our program goal was to develop enduring materials to help provide patients and providers make shared decisions. And when we say, patients and providers, we also include caregivers, and you'll hear a lot of caregiver voices throughout this presentation. And then recommend positive steps and actions that we can take to improve shared decision making and dismantle barriers to equity and access. And as we've seen, equity and access have multiple faces, have multiple causes, and therefore have many different kinds of solutions. So the project, we started out learning from communities, and we started out co-creating communities. And we did 3 in-person workshops co-created with community partners. You saw a few of the photographs from Mississippi, from Richmond, and from LA County. So our partners chose the locations, they invited the participants, and they participated actively in setting the agenda. There were a few things that we carried through from place to place. We did pretty deep evaluation of the impact of these workshops, but we also had things that were very different in each of the workshops, including some of the questions that we asked, and those were developed. We developed those in partnership with our with the partners we worked with. The participants included people with cancer and other serious illnesses, as well as caregivers and health providers. And you saw that in the last panel with Sharon Rivera and Tamron Collins and George Trong. And that was done very intentionally, because this is not, as Dr. Gwen suggested, a one-person monologue, but it's actually a dialogue. And in order to make change, we need a dialogue. Participants were paid honoraria for their time and effort. We honored and we valued what we wanted to make sure that our values of honoring and valuing and respecting individuals meant that we also practiced equitable budgeting. And the workshops were highly interactive. So we did, these are our 3 workshops. We incorporated group discussion, storytelling, and active listening components. And the participants completed extensive post-survey results. And you'll hear from Chris Wilson a lot of what we've learned, and a lot of things were counter to what some of the things were counter to what we expected. We're in the midst of creating and disseminating enduring materials and recommendations to our partners, advocates, and healthcare providers, along with an advocacy curriculum that builds on some of the things that we learned, and some of the things that patients and caregivers said that they wanted to become more skilled in at the workshops. So these are the demographics, and I will say these are the demographics of people who answered our survey. In Los Angeles, we did not have enough time at the end for people to participate, and so we had a little lower participation. That is a really critical lesson learned, is that we have to have enough time at the end for people to be able to fill out the evaluation on site. So here's the age range, the income, female, employed, non-white. The non-white percentage would probably go up to about 85 if we included all of Los Angeles County, college degrees, Hispanic, and then people who are in Medicare and Medicaid. So these are the locations and the roles, and as you can see, you can see the participation in the survey, and then you can see that while the majority of people were patients, there were also significant caregivers and healthcare providers who participated in this workshop. So this is how we these are some of the ways that we co-created programs with our partners. So the key workshop components we're working with and learning from the community, and it's something that we talk about in all of our work. It's something that we emphasize in all of our work, but we learn from people, we learn with people, and I love that addition of learning with people. We were hearing and listening to the voices of our participants. And as Rob Wynn said, we're not just seeing people, but we're also hearing people. And we have to make sure that we hear, we don't just see. And we also don't see them through our own lens of preconceived assumptions. We see them, we step back and see them as they want to be seen. And that's always that's always a goal in every interaction and every relationship that we have, whether it's that we all have, whether it's professional, personal, family. And we also wanted to, as I mentioned above, bring caregivers and providers together. And this was really, really important to create that dialogue and also understand, have everybody learn from each other. It wasn't just a one-directional learning, it was a multi-directional learning. And here we focused on both the individual and the broader systemic issues that influence shared decision-making. And I know I've been doing advocacy for a very long time. I counted the other day, it's 27 years since my first diagnosis of cancer. I'm a 3-time cancer survivor. And one of the things that was so clear after my first diagnosis is that everybody has their own individual experience, but there's also a communal experience. There's a social experience, there's a systemic experience. And we talked earlier, the panelists and Dr. Gwen, about the broader systemic issues that influence shared decision-making and the choices that people have. We also, the other aspect of this that is incredibly important is to build and sustain long-term trusting relationships with our partners. And we don't come and leave, we don't come one time, we build relationships over years. And we intend to continue to do this for as long as we do this work. So here is Freddie White Johnson in the middle from Mississippi Delta. This was our workshop in the community center at the in Ruralville, Mississippi. Here's Sharon Rivera Sanchez, who you just saw on the panel, and you can see Dr. Wynn's hands clapping. You see the little edge of Dr. Wynn, and we are in the Lewis Ginter Botanical Gardens in Richmond, Virginia. And then here we are in Los Angeles at the Freedom Hall, Los Angeles Freedom Hall, and this is all of the participants wanted to share, and they shared so deeply, and we were in a place with so much history. So, if we could start with the second video, please.
I think this partnership between the NPAF and Massey Cancer Center was born out of the spirit of disruption. And what I mean by that is that typically we talk past one another, we talk at one another, but we rarely speak to one another in a way, or speak with, that all of a sudden there is almost a collective intelligence that sort of grows from that. The effort today here at Lewis Ginter was really one of the best examples of what happens when you disrupt the myths that people don't want to sit and ultimately have open, honest conversations. Today, this meeting disrupted the things that cancer centers only want to kind of hear from you, but they just want to check a box and then move on and say, we did a community event. Today, people said they felt heard. Today, people said they felt seen. Today was one of those victories, small victories as it is, in which we talk about the invisible millions, the invisible communities, the people who don't have voices at the table. Today's a small victory in which a cancer center, an organization that's a patient advocate, but more importantly, our community came together to be seen, to be heard, and to feel the passion that we all have for one team, and that's one goal, and that's to cure cancer and to make sure we do it better.
I had an opportunity to be involved in the planning, conceptualizing what we're going to do, design the marketing tools that we're going to use to tailor them to meet the characteristics of our community. I felt ownership. I felt very much part. And most importantly, resembling very much values that I appreciate, that is inclusion, making sure community is part of the process. So to build trust meant that I needed to use the channels that are approved by this community, the African American community in Los Angeles. So for me was to reach out to trusted leaders first, ask them for them to trust me by explaining what was the process about and what was the expected outcome and what was the benefit for the community. Having done that, created an opportunity for them to open their networks. Key people on the community, key leaders that were able to take time out of their busy schedule to speak with me, understand the process, what is that the project was all about, what is that we were attempting to achieve. And in turn, they put me in contact with people that felt aware, the right people, not only meeting the criteria for the project, but they could speak about in an articulate way about what was the problem and what were the needs that they have and what is that they needed really, and do some advocacy around. So one of the things that African American community, disadvantaged, disenfranchised African American communities have done through centuries is to survive, touch, and really connect with others and with the spirit and never give up. So I feel that that is something that is built over time, and that is at the end what keep us, because I'm part of that community, keep us going, never losing hope. I believe that as a result of this experience, individuals and families that have been battling, that's a thought that came to me, with cancer and with the lack of access to resources, had the opportunity to experience hope again. So as a group, we would like to continue in this direction where we need to move away just hoping, but actually into action. At the end of the educational workshop, some of us start entertaining the thought of building a movement to improve access to comprehensive care for individuals living with cancer. I think the African American community in South Los Angeles not only have the strength, has the knowledge, and my hope is that we can develop the advocacy skills needed to achieve goals for increased access to equitable and quality healthcare. I have to tell you that Wax Labor Community Center is at the heart of South Los Angeles. And when we were planning for this event, we were planning for a place where the community feels safe, a community that have been part of the whole movement of the 60s. They built this in memory of what they went through. And today is a safe place where they come and their needs and rights are respected and defended. I felt also that the symbol of the site, the Freedom Hall, will give our participants an opportunity to feel strong and be able to raise their voices. And I think it did the work. I think it's very important that in efforts to bring health equity, we rewrite history here. We know that African American communities in the past have been, victims, I will use that term, of some activities in the healthcare field that resulted in damage done to them. So over time, we have seen many academic institutions and researchers coming into the community. And at the end of the day, see no results, not even what happened with the information that was collected. So we're looking for partners that have credibility, as I said before, that share values, that give opportunity to co-create like we did. And at the end of the day, it's there for the community all the way. So no short term. One of the things that we're doing is beginning to reconnect with the group, because I think with funding or without funding, the need is there. the motivation is there. They spoke about building a movement, and this is something that we are interested as well. And before we end, I would like to give you thanks because through this partnership and project, you give us the opportunity to look at one of the issues impacting African American communities, older adult African Americans, that we were not aware. It provided me personally the opportunity to learn how depleted is South Los Angeles of appropriate cancer care. So this is something that we'll continue to work together.
Rob, Gwen, and Viviana, and also Freddie, Freddie, who worked with us in Mississippi, but who was not able to share her thoughts on our video. So now what we want to do is talk about the work we've done, what we learned from this, what we took away from it. We knew when we went in that we were dealing with a growing community of people. If you think back, and Rob Wynn talked about this, it's not really that long ago, 10, 15 years, that people with lung cancer, melanoma, multiple myeloma, various leukemias and lymphomas, breast cancer, the list goes on, as well as various types of heart disease and other conditions, didn't have to worry about long-term shared decision-making because most of them were dead within a few months or a year of their diagnosis. Now we have a growing community of people who are living with a disease that is not cured, is either in remission and they have a fear of recurrence or have active disease and are being treated successfully with the new therapies that exist. But those people do not just live in a vacuum. They are not just patients. They are people who, as we've talked about already, live in communities, and they live in a healthcare system that influences their access to care and their ability. When we talk about making shared decisions, you can't make shared decisions with your healthcare team if you don't have access to the care in the first place. So what we want to talk about now is what we came away with when having these conversations and these interactive workshops with this group. First of all, I want to just make the point that I personally don't think I've ever heard a patient use the term shared decision making, but they do understand very well what it means to communicate with their healthcare teams and to be partners with them and to be respected. So shared decision making, in however you construe it, whatever language you use to describe it, really depends on the fundamental principle is that mutual trust between patients and their providers, and this sense that patients very, very much want to have a relationship with their providers. And I think this is particularly true for people who are dealing with making decisions not over a period of a few weeks or a few months, but over a period of years, where these decisions come up over and over again at critical junctures in their treatment and their care. And that these decisions also relate both to their treatment options, but also to their lives. And I think we heard that in the panel, and we'll talk a little more about that. For some people, one obstacle that is not so much a systemic obstacle, but is more kind of a kind of historical or obstacle, is this continued fear of being judged. And by being judged, people are in our groups brought up, they were worried about being judged, blamed for their disease, stigmatized by having certain types of illnesses. Some people are worried about issues related to their sexuality or to some of the things in their personal lives. Others are very concerned, and this issue comes up all the time, about their insurance status and whether they will receive inferior care because they don't have the right insurance or they don't have any insurance. So that fear of being judged continues to be an obstacle to good communications and to shared decision making. Time, we've talked about time. Time is, of course, a major factor in how all of us access our health care and how well patients and providers communicate. But I think what we found is, and we'll talk about this a little more, is that as people go through the system, they get better at understanding how to use the time that is available for them and making good use of that time. So it's not that it's not a factor, and it's not that healthcare providers are not overburdened with huge numbers of patients, particularly in underserved area, but there are also some skills and experience factors that can be brought to bear and how to use that time well. Next slide, Gwen. So this is some of the data that we got from the evaluations that we asked people to fill out. The evaluations were not just how'd you like the program. We really also wanted to know about the issues that we were dealing with. And it is possible that these groups were somewhat self-selected because they were people who agreed to come to 4-hour workshops, on 2 of them on Saturdays, and to be part of our group. But you can see that overwhelmingly in this group of people who are dealing with disease or cancer or other diseases on a long-term basis, they have pretty good relationships with their doctors. And they think it's important that the doctor knows something about them. Their healthcare treats them with respect, 86%. My healthcare team explains my treatment options. Again, same percentage, 86, 87%. My healthcare team listens to me, and I feel I can communicate with my healthcare team. Those are very strong figures. And I think that it speaks to the fact that as people go through the system, they become better at working with the system and getting the kind of care that they need and expect. Next slide. Nope, wrong direction, Gwen. Next slide. Nope, we're going backwards.
Chris, that's the next slide because it's what we learned about information.
Oh, I thought there was another slide with data on it. Okay.
Now, after this.
Oh, all right. All right. Sorry. My fault. So another thing that we learned is that patients want enough. Okay. Is that where we are, Gwen?
Yes, that's
Okay.
the other data slide. Sorry. My apologies.
Okay. All right. We're in sync here. Patients want information. They want information up front. And this notion that the healthcare provider, and also that the healthcare providers are actually asking about what's important to the patient, not just telling them what they need to be done. So that notion that the healthcare provider asks me what is important to me in making decisions, it's really key to a shared decision making. And my healthcare team gives me the information I need to make those decisions. I feel confident in advocating for myself to get the treatment. And again, I think there's a lot that comes with experience and being part of the system. People gather confidence as they go forward. 73% said my illness has changed my life in so many ways. And when you think about that and what it means in terms of the number of decisions that people have to make and the kinds of decisions they make, it's really significant. And then again, 80% in the time since my diagnosis, I have learned a lot about my treatment and condition. So people change, they evolve, they're as they go through the experience, they know more, they know how to ask questions, and they become better self-advocates. And we'll talk a little later about how they become increasingly better advocates for their communities as well. So some of the questions that are difficult for people, and we asked we did this in our interactive groups. We said that, what are the hard conversations to have? What are the things that you don't really like to bring up with your doctor? So one of the things that came up very consistently, and it seems kind of obvious, but to be honest, I hadn't really thought of it this way, is people really are reluctant to talk about changes in their treatment or ending treatment, particularly when those conversations involve bad news. If you think about this cohort of patients and caregivers, they're frequently on a treatment that works for a while, then it stops working and it's time to change treatment. Those are hard conversations to have. It was working, but the scans aren't good. We need to move forward with something else, or we've run out of options. And we maybe need to think about hospice or end of life care. So there's conversations that involve bad news or things that you're going along, you think you're doing okay, and then the scan isn't good and you've got to change what you're doing. Those are hard conversations to have, hard conversations to make shared decisions about. Again, talking about cost of care and insurance issues we've done quite a bit of work in this area, is extremely difficult for people, particularly when they feel that if they can't afford something or if there are issues related to paying for their care, then it's going to mean that they get second-rate care or they don't have access to the best care. And there's a reality to that. Some of it is perception, not reality, but as Dr. Gwen pointed out, there's a definite reality. There was a study that came out yesterday about access to lung cancer care, showing that, as Dr. Gwen was saying, that there's been a significant improvement in lung cancer survival, but that there's still a remarkable gap with Black and brown patients, and that includes treatment and screening. So those people can't afford it, they don't have the right insurance, or they just simply don't have access. Interestingly, again, I don't think we had really thought about this so much, but and this came out particularly in Los Angeles, where we had a lot of older patients, cancer patients. When the patient decides that he or she wants to do something different, stop treatment, take a treatment gap, change things, or maybe just say, I'm done, I don't want to do this anymore. They find it very difficult to have those conversations in which family members are involved and may disagree about the patient's choices. We had one person who actually said that she had decided to give her body to science after she died, and was treated with a lot of her family members really didn't want her to do that. They were kind of horrified by that decision. But also just the notion, I'm tired, I think I've had enough, I want to quit. Very often family members will push back against that. And so those are hard conversations to have. And they're hard conversations in which the patient and caregivers feel like they're all kind of making shared decisions together. Next slide. So patients want enough information to make good decisions, and they want that information up front, if possible. And this was interesting to us. In two of the areas we were in, one very rural, everybody had a smartphone. Everybody uses it. They were very proficient with it. They use it to get information. And they also, the next slide will show you this, use their patient portals a lot. So there's been this sense that there's a gap, that patients don't use that kind of technology. But where we find that the gap is in access to good Wi-Fi. And again, today there's a story about how there's a huge gap or lack of good Wi-Fi in many, particularly rural areas. But we shouldn't assume that people will not use their technology or that they don't have access to it. They just use it primarily over their phones and with their electronic medical records. As we've noted, people facing serious illness over time become educated about their conditions and better able to navigate the healthcare system. And patients really talk about how much they value support from others facing similar illnesses and patient support groups. That notion of having somebody who's shared your experience that you can talk to and get information from and support from is really important as people go through these long-term journeys. And this is our response for the portal use. And in all, this is from all three, 80 to 90% of people say they use their electronic patient portals. So this really means that there's a real role for those. Another really strong theme that we heard, patients, as they become more proficient and better, more skilled at dealing with their own conditions, just overwhelmingly talk about wanting to pay it forward, to use their experience to advocate for others and to help others facing illness. They want to become those support people for others that are going through what they're going through. And that's actually a really important theme and something that we think that we can really build on. I mean, we worked through our advocacy curriculum and trying to help people develop the skills to become better advocates for themselves and others. But it's something that is really characteristic of this group of patients. So common themes in all three areas, and they were quite different. But one very rural, one very urban, and one kind of Richmond, kind of in between. A very strong sense of community amongst the people, and a very strong sense of shared experience, and wanting to tell their stories, to be heard, and to listen to other people's stories. people seem to get enormous strength and satisfaction out of telling their stories, but also hearing other people's stories. Overall, they report really good, trusting relationships with their providers, which is really important when you're dealing with illness over a very long period of time. And that desire to become better self and community advocates that we just talked about. There were some differences. In the Mississippi Delta, there's just generally poor access to care. You heard that from Cameron. You'll hear it in the next little video that we have. The lack of Medicaid expansion in that state, and I think there are now 10 states that still have failed to do that, is really critical. There was a hospital in Greenwood, Mississippi that you'll hear about in a minute. That was a huge community resource and a very good hospital that closed. And that's why patients are now having to be transported to distant specialty centers for essentially any kind of specialty care. And also in those areas, there are very few primary doctors, so that the doctors that are there are heavily burdened, have a very heavy patient burden, and there's a real need, as Cameron pointed out, for nurse practitioners and for people who can provide that primary care to a large populations of people who need it so badly. In Richmond, we had the privilege of dealing with a group of patients who were, for the most part, being treated at the Massive Comprehensive Cancer Center, which is, I think most people know, is really the kind of the model for comprehensive care and for a team approach to care. And they spoke very positively and had very strong relationships and a high degree of confidence in their treatment and care and in that team-based approach. So that's a real strong point for people who have access to that kind of care. In Los Angeles, the big city, there are 3 comprehensive cancer centers in that city with a very strong medical system and resources, but the people that we talk to and watch do not feel like they have access to that care. Some of it's because practitioners and specialists won't accept the Medi-Cal, which is the equivalent to Medicaid there. And some of it is, we talk about distances in rural areas being 2 hours. It can take 2 hours in Los Angeles to get across town. So that the notion of transportation problems, distances, just access, like physical access to care, was a major issue there. And I think we're ready now. We wanted to hear. It's great to hear from Gwen and me. We love to talk about the work, but we also wanted to let you hear what some of the patients that we worked with and caregivers talked about. So the next video that you're going to see is just a sort of a short kind of a bringing together of those voices, so letting them speak for themselves.
Well, right here in the Mississippi Delta is very hard, and we are struggling here of losing the hospital here in Greenwood. I'm no longer on the board. I've been gone 5 years, but the hospital is in a situation now that's about to close. At one time, this hospital was the best hospital in this Delta. The hospital was over 200-bed hospital, and we had all services there. We even had neurosurgeons. You had orthopedics, general surgery. You had the ENT. I mean, you obstetric. I mean, we don't even have obstetrics in now. You don't even have the children's clinic anymore. So now, when a person is sick, right now, what we expect and hoping, everybody hoping that something is going to happen where the hospital will be saved, because, and basically, if you go over there now, there's not a whole lot they can do. Most of you going to be shipped out to somewhere. And right now, it's tough. You never know. You may end up in Alabama.
It's really hurtful because I've heard people say someone was doing well with the cancer. Because of the hospital closing, they're not getting the care that they previously were getting. And it's been said that some feel as though the death rate of those who had cancer is more now than it was before the hospital with the financial issues. And I could see some things because the night my husband got sick, they had to rush him to another town about an hour and a half away. So there was no emergency here.
Situations keep changing. Doctors keep leaving. Uh, uh, Primary care providers change.
My husband is a prostate cancer survivor. He was diagnosed in 2020. We had to, of course, go outside of our zip code to find services. We advocated by researching different types of cancer treatment for the prostate through Dr. Google, both through at Cedars, Yorba Linda, and then down in San Diego, and another hospital in Orange County.
Most Black and brown people are not even being asked about a clinical trial. I found my clinical trial on my own. So what I got involved is like make sure that we get the information out to all population and especially the underserved. And, you know, where can I come in? Where can I help them at?
The decision-making process was, you get flooded with information, but we were nurtured through that, I think, very well, to be able to make what we think was the right decision at the time for what she had. And it is fatiguing for both of us, but it is a glorious gift to God that we're moving on.
That was a phenomenal time of the year. It was 2014 when I first felt that pain again. It was easy to talk to. She brought myself and my husband in, and we sat down. She talked. She gave me terminology. I mean, the hospital was great. A book about this size was given to me with a whole lot of terms in it. So I had a chance to read up on what was going to happen to me. So that was interesting. I mean, it was great. I mean, I can almost describe how it felt just to have someone and know that I had a person like that. She was so easy to talk to. Sometimes I would go in and she would put the x-rays up there and I'd be on her shoulder and she would tell me, you get back, you're trying to find something else. I'll be trying to say, what's that? What's that right there? And she'll say, okay, let's not try to find anything else. Just a dynamic person. And she made a statement to me that one reason what made her go into the field was that when her mother was diagnosed with cancer and her father would work all day, they'd come to the hospital, and she just felt they were not treated well. And I think that was some of that closeness.
Continue to look. Don't be satisfied with just one organization, because some may provide information, some may not provide enough information. So just keep searching.
Based on the meeting that I went to, what y'all did was a great meeting, and because a lot of people, like I said, when they go to the doctors, they sometimes feel afraid to ask questions. And sometimes they could go there and have things wrong with them and they won't actually, some doctors, bedside manners are not that great. And you got some, they sit there and take the time with the patient. But what happened in a lot of cases, some of them have so many patients they have to see in a day. I don't want to just beat them all the way down, but they can't stay in the room that long. But, you have to be that someone that goes with your parents or your loved one that's going to get their attention when you go there. And it's, hey, I need to ask you these questions. You might he's trying to run the room, so you hold him there and ask what you need to find out to get that person in the right direction. Because a lot of times what happens, to me, that's just a wasted doctor visit. If you go there and you didn't get the information that you needed, and then just pat you on the back, so I'll see you next month. But you still have the same problem. It never was addressed. And that happens so many times with a lot of people, because a lot of times they go there and they really don't know what to ask. They just follow instructions and wait, pat them on the back. Well, I'll see you next month. Okay, you still had the same problem and it never was addressed.
I appreciate the VA, but oftentimes when I go to a clinic, whether it's 6 months or a year and a half before I have another checkup or just go in for routine stuff, it's a different provider there. Now, I'm not saying they're not good, but everybody appreciate a little consistency, and oftentimes we as men and I'm talking about men in general, we really, a lot of people think women want it, but men in general, we want consistency too. Otherwise, we won't even fool with it. That's been my experience, per se.
It allows me to have that sense of credibility with them because, as you said, there are things that they convey to the doctor and it goes right over their head. But because I have shared experience, I hear it. And so I'm able to go back and speak with the patient and say, hey, I heard you say, how can we best suit you so you can be comfortable in whatever this is?
I'm here because I want to pay it forward. I do want to pay it forward. It's things that I learned as a young breast cancer, on my breast cancer journey that really helped me out, that I want to make sure that I share and that I'm here to get what you guys have and how you guys made it too. I'm also a chaplain at the VA Medical Center in Richmond, and I'm going to be working on the oncology unit next year. And so I really want to learn from all of you and get what I can get so I can also bring it to the veterans. Because some things that hurt me that they don't have, that we have at Massey. And it's important. I believe it's by purpose that I'm here because I'm going to bring it to them. So I'm going to soak up everything you have. I got my pen, everything. And I'm going to take it back to our veterans. Thank y'all so much.
What I do, I write it down, then I ask the doctor those questions. And that has helped. And those are some things I pass on to other people too. And even with the cancer, I tell people sometimes keep a log of when something hurts. When the pain was, and sometimes that helped the doctor to help you in diagnosing what your problems are or how your body works.
Because I was stationed at the home of U.S. naval submarines and where they build submarines, had opportunity to get out and get paid well to do a lot of the things I was already doing for the Navy. But in the end, after much prayer and realization, something kept hitting me, said, go back home and try to be an integral part of your community at home. You've done a lot for yourself. And what you've done for yourself should be able to sustain you while you go out here and try to work it any way possible with your community.
Every time I've seen those videos, it just takes me back to the Mississippi Delta, Richmond, Virginia, and LA County. They're so evocative of what we learned there and the relationships we saw that were built, and reinforces and redoubles our commitment to continuing to work with these groups. So I wanted to just talk a little bit very quickly about our next steps. We're going to return to our partners for further work and shared decision making, and to develop and test patient-focused materials for people facing illness and serious illnesses on a chronic basis. We're going to focus on gaining on barriers to gaining access and work to dismantle those barriers. And we're going to develop advocacy models that are specifically for this patient population and these communities, and really build upon what much of what we heard, which was giving back. And I came back home to give back. We will also partner with a large professional group to disseminate these materials to key stakeholders. And we're going to expand our storytelling and active listening workshops to involve more patients and communities facing illness, serious illness on a long-term basis.